a lot of energy to adopt technologies and solutions people like you might come up with, which save money and address those earlier things I talked about. Health reform, despite our agreeing with Prannoy's opening that it's a good day and things are going in the right direction with the reform law, it isn't going to save money. It's not going to bend the curve. And that's a really profound concern by the employers. And then consolidation, market consolidation is a huge issue for us. That is large insurance companies and large hospital and delivery systems merging into very large concentrations of market power in a community and basically setting prices and creating monopolies in communities. That's happening a lot in California, and it's a concern.
I think to that last point, it's not just consolidated of payers and payers, but payers crossing the line, playing a different role as player/provider in some places. And how much do you think that's going to be a driver in terms of how the provider space has changed when the payers tightly integrated? They're not all fully staffed models, of course, like the Kaisers are, but certainly there's more skin in the game from the payer when they're a provider as well.
Yeah, we're definitely worried about those trends. So the trends, again, if you couldn't hear it, is different actors are buying each other. And all over the country, we're seeing hospitals buying doctors, health plans buying hospitals, with dialysis company buying a medical group. So it's a really interesting time, which is good, but very uncertain and makes people queasy because everyone's just chasing money. And that's the way we've created our healthcare system is very much driven by relatively short-term profit taking. And it's very disquieting if you're concerned about, if you're a large company, you've got a workforce of people who are 35 and you want to still employ them when they're 55. You're not that interested in this, moving the pawn pieces around the table.
Have you seen much activity at the DOJ regarding the mergers and acquisitions of some of these large systems in terms of antitrust and so forth? Are they becoming, I've seen some activity in Chicago where they've been quite active, and also in Illinois. However, I haven't really seen that much going on here in California.
Yeah, they are quietly giving it more attention than they were before. I think they love this concern. They have now begun to appreciate it. So yes, I think there'll be more of that. So what we're doing in our organization is really 4 strategies. Consumer engagement, so people are choosing the right care providers and treatments and technologies. Payment change, so we're incentivizing providers to choose the right services and technologies. Really getting our hands dirty with redesign of the care system to disrupt it, because we think the current models are not working terribly well. And then looking at the policy environment for the national healthcare reform, state legislation, antitrust issues, and saying what can we do to create an ecosystem which creates a more robust competitive marketplace where innovation can be supported. So these are examples of the kinds of things we do in each of those 4 categories, and you can eyeball them yourselves. You can see in the back. A lot of work on transparency, both quality and cost. A lot of work around this shopping model, consumer choice models. How do we give people information and incentives to choose the more cost-effective services? Tools, we do a fair amount of tool development in terms of consumer decision support. I know some of you work in that space. We try to move payment toward global payments for value instead of fee-for-service episodic individual payments. And I'll talk in a minute about the redesigning care work. So I want to give you a few things I think large employers think about when they look at new technology adoption and innovation. First of all, what's valuable is that which produces better outcomes or is cheaper and gets the same outcomes. It's a really simple rule of thumb that I think most purchasers bring to conversations with folks like you. Secondly, they almost will never pay for new technology. You can't go into the benefits department at Chevron or Intel or Cisco and say, I've got a great new gadget that'll really help your employees, why don't you buy it or pay for it? They won't. Very, very rare. So instead, they're going to try to find a way to get their health plan to cover it, or to have a consumer-directed benefit design which will incent people to use it. But it's an indirect model, at least as far as our community goes. What they want to pay for is say to the physicians and the clinics and the hospitals, I want you to get better outcomes. Now, if you need to go buy that new asthma gadget from an inventor of a new asthma gadget that'll produce a better outcome, go do it. I will incent you to achieve a better outcome, but I won't incent you to buy the gadget. So that's the paradigm, at least, of the employers. Measuring and monitoring appropriateness is a big deal. So if we introduce a new technology, a protein beam therapy, it might be great for a tiny number of people, but then we've seen over and over again it gets applied to 100 times as many people who aren't really the primary beneficiaries, who could do just as well with a less expensive technology. So show me that what you're doing will be used appropriately and not drive up my total cost. Comparative effectiveness research, there's this new institute, PCORI, a federal institute, to study what works in healthcare. It has been prohibited by Congress from studying what's cost effective. We don't think that's the right course, and we would support consumer effectiveness models which do include, comparative effectiveness that does include cost. Aligning payment is a big thing. And then the last thing I mentioned here is total cost of care, meaning there's a lot of interest in this, which is saying I don't want to look at that hospitalization or that doctor visit or that month of rehab care. I want to look at a year or 3 years of care. What did the whole episode of that heart attack or that knee replacement or that asthma 5-year-old episode, what did that cost as a whole? And then let's look at the components that were put together to optimize the cost over time. Yeah.
Can you talk a little bit more about the second one, the don't pay reference technology for outcomes?
Yeah.
So they can, especially in this region of the country, when you have innovative technologies, there's a business plan and a promise of an outcome, but not a whole lot of proof over 3 years of what the actual equivalent
Yeah.
industry. So how do you get that case across to?
Well, my companies are not typically early adopters. They're going to wait to see some of that evidence from other trials and pilots and prototypes. So I think gathering data that would convince them that this is true as you do those early experiments is really important. There's some exceptions to all those, not my generalizations, but in general, that's how they're going to come at it.
My question is to your last point about the total cost of care. That was actually done already back in the 80s with DRGs, the formation of DRGs, diagnosis-related groups, where you're looking at a whole episode of care, and looking at the individual components of that care along the way. And DRGs, I believe, are still around, but they're not really being used to the full extent of looking at a whole episode of care or the time frame going from beginning of the heart attack, maybe, or the heart condition. That's unknown. Maybe they'll take it back to when the person started eating 20 years ago and really looking at that whole episode, which is a more appropriate, comparison. But I guess, are you suggesting that we're going to start seeing this DRG-like focus again?
Yeah, I was just reading a paper this morning that's talking about how to clump DRGs together and make a meta DRG or a mega DRG. So episodes of care is the term of art right now, and bundled payments. And both of those imply a longer time frame. A DRG is typically a hospitalization.
Right.
But if you take the 30 days before the hospitalization and the 90 days after the hospitalization and call that a single payment, that's an episode. That would be a big construct. So that's where that's going.
And is this related to the ACO model? And
Yeah.
it is. Okay.
Yeah. So let me give you 4 quick examples of what our members are looking for from innovation, and especially from technology innovation. First is something we've been working on called the intensive outpatient care model. Second is innovation in colorectal screening. Third are devices. And fourth is diagnostic testing. So the first one, this is a primary care case management model. Basically identify the 10% or so really sick, really expensive patients who keep falling through the cracks, have terrible problems, often behavioral health comorbidities, multiple chronic illness, chew up money, go on years and years in and out of the emergency room. If you read the Atul Gawande piece about a year and a half ago on hotspotting, that's this population in Camden, New Jersey. So what Boeing did in Seattle, Boeing as an employer said, we're sick and tired of this, we're spending millions of dollars on these people, they're not getting better, we're writing all these checks, this is crazy. We're just going to go in there and meet with the big medical groups in Seattle, and we're going to hire nurses for them. We're going to train the nurses ourselves, we Boeing. We're going to install those nurses in these clinics, and we're just going to manage the heck out of these really sick people. And we're going to run an algorithm against a big data set to identify who is likely to be benefited by this model of care. So they married up a case-finding algorithm of identifying these candidate patients with a primary care assessment strategy of who can deliver this kind of care, inserted a trained nurse into the group, and then tracked it. They developed a whole feedback system, so there are dashboards giving the doctors and nurses really tight daily feedback on how these patients are doing, where they're falling through the cracks. They saved 20% on costs for this population, reduced admissions by 28%, increased their mental health functioning scores by 16%. Patients were satisfied, felt like they had 18% better access to care when they needed it, and their 56% decline in lost work time in this population. This is a tiny number of people, there's 700 people who are really sick, really expensive. These are $1 million patients. And if you get on top of this group, you're really making a difference in the cost of healthcare, and you're improving lives for 700 people.
So these are the individuals who work for Boeing?
Yeah, and their family members.
And their family members.
Yeah.
So how do you broach the subject that they or their loved ones are frequent flyers and
Well, actually, typically you don't. So the way this was done is by their current primary care doctor said, gee, Mrs. Smith, you know, we have this other program across the street, which is really great. I know you've been really frustrated. You've been in the emergency room 3 times this year. I know you're having trouble staying on your medicines. I know you can't get out of bed in the morning because you're really feeling lousy. I think this group across the street can really help you out. You can come back and see me whenever you want, but why don't you give this a try? So that physician referral was really critical, and not breaking the bond of trust that those people often have with their providers. So I just want to give you that example. We then did the same model in Humboldt County, California, and in Orange County, California, with different employers. PGE here, CalPERS, where their employees were brought into this kind of program. Boeing remained very involved as a guidance. We then sent this as a proposal to Medicare and said, why don't we do this for all California Medicare population, which is really where a lot of this chronic care falling through the cracks is. And we just a couple weeks ago got a $19 million contract for Medicare to do the same thing statewide in California, and actually probably Arizona as well. So this is an example of employers, Boeing in this case, stepping out, developing a model, really getting their hands dirty with the care model, innovating. And there was a lot of technology innovation here. There were care management models, measures, feedback, evaluation systems, the care delivery model itself. That was not nuts and bolts hardware, but it was soft process technology that made a huge difference in the lives of these people and in the program, and has multiplied out. So that's a soft innovation. Employers love that stuff. Second example, colorectal cancer. This is more nuts and bolts. Today, this is Canadian dollars, but you can guess your own numbers. You saw the colonoscopy data earlier. In whatever this time frame was, 2000, I don't know, it says on the bottom below, before 2010, colorectal diagnostic screening was 857 Canadian dollars on this slide. A new test called the FIT test is $19 Canadian. Has to be done more often. It's much less invasive, much easier to do. It's self-administered. Has been very, very slow to get adopted. So there's a program actually at Stanford, a think tank at Stanford, saying, how do we get adoption of this $19 technology to replace this $1,000 technology, which no one wants to do a colonoscopy. One of the problems with it, you see on this slide, is that 40% of the people don't want to do it. They won't get their colorectal screen, including my mother, by the way. She just won't go through the procedure, never has. So that's a technology, it's an established technology, it works fairly well, but we can't get people to do it. Now we've got a much cheaper technology, which is much easier to self-administer. How do we get people to do it? So what this institute is doing is looking at the entire, as you see here, the workflow, and both the cultural, psychological, business, and technical issues of implementation, and saying, how do we get this much cheaper technology widely adopted? So that's very attractive to employers. They'd love to sign up for a program of cheaper technology, wider adoption, save more lives, detect more cancers, save money too. Good thing. Third example, implant selection. This is trend data on the cost of orthopedic surgery, hip replacements and knee replacements from 1992-ish. And you see this is what doctors get paid to do the surgery, flat line. This is what hospitals take in revenue, flat line, 20-year flat line. Where's the steep curve? New technology. Huge increase in the implant list price for the coated hip and the selling price for the hip. Have we had a benefit to society by the increased cost of the technology? One of the interesting sort of ironies of this is that the new models of the implants are actually, some of them are great, some of them are actually dangerous and bad, and you've probably seen headlines about them being pulled out of patients because the new technology was brought in too fast and wasn't evaluated well. Now, interestingly, in Sweden, where they have a national registry, and they've been tracking this very closely, they use about 4 products and have since the mid-90s. And their revision rate, the rate at which they take out bad hip implants, is about 1/3 of what ours is. Ours is about 8% of people have their hips removed because of failure. In Sweden, it's about 3%. They're using an older, established, basically generic technology which works fine, a cemented technology. We went down a technology development path that was ambitious, uncemented, new titanium products, very expensive, a lot of marketing behind it. We have, for example, the pink hip, which was for women, which had no functional advantage, but it was a very good marketing strategy. And so we ended up with headlines like this, that the new technology for artificial hips and knees is not better. So what we've been doing as employers is building a registry in California, the California Joint Replacement Registry, to collect data from all the implants done in California, give the data back to the surgeons and hospitals to show them what is happening with these devices, and that they will be more careful about the selection of devices and how they match to patients. Because like Sweden and New Zealand and Australia and Norway, England, we will finally have a registry to keep track of these products, detect problems early, and address them quickly, instead of waiting 5 years longer than other countries do to correct problems in these models. So the kinds of things that the California Joint Replacement Registry is worried about or interested in is helping people improve which patients get which devices fit to which patients, managing the care process better, and so on. I'm going to keep going through to get to the end, then we'll take a few minutes for discussion because Laura's doing her job. Same thing for cardiac interventions. These are stents inside your coronary arteries. Overuse stents in stable patients, very widespread, probably a third to a half are unnecessary, inappropriate. The American College of Cardiology, the cardiologists themselves, finally got together and made a list of what is appropriate uses for stents. And in doing their list, they actually wrote a little statement to people like me that says, services performed for appropriate indications should receive reimbursement. In contrast, services performed for inappropriate indications should not be paid for. This is fantastic. The doctors actually said, don't pay us to do the wrong, unnecessary stuff. So now the question is, how do we implement this in the real world? And I would love for some of you to solve this problem, because what we don't have is a methodology for observing conformity or non-conformity to these guidelines, and then setting payment and recognition and consumer incentives. So if I need a stent, I want to go to the people who use this technology appropriately, not to the ones who might be like those colonoscopies on the far right side of the chart. Last example is pure consumerism, pure consumer play. You may have seen this about a month ago. 9 medical societies, the kidney doctors and the family doctors, got together and put together, each of them, a list of 5 things in their specialty that don't need to be done, or not done as often. And they, again, like my previous example, they basically said, fellow physicians, don't do these 5 things. Even though you could and have been, don't do them. But their strategy